Hello. We're going to go over calcium highs and lows today. So let's get started. So hello, my name is Rhoda Summer, and I am the owner and tutor here at One-on-One NCLEX Tutoring. There are other tutors that have joined me, and we are here to help nursing students learn so they can pass the test, whether it be in school or whether it be for the NCLEX. Today, we're going to cover calcium and what it does in the body, hypocalcemia, hypercalcemia, and the treatment of both conditions. So I had to throw something funny in here. You might have to think about it a little bit. If I were a metal, I would be calcium. Most wouldn't know me as one and wouldn't acknowledge unless I'm either hyper or hypo. Think about that for a minute. Hopefully you'll find that kind of funny. I do. What is this calcium about? Well, calcium is the most abundant cation in the intracellular fluid. The normal is 3.5 to 5, and that's not true. I want you to go find the real amount. I will tell you later in the program, but at this point, just know that those are not correct. Calcium promotes the transmission of nerve impulses. It's the major component in bones. It regulates muscle contractions. It maintains the cardiac muscle's contractibility, and it's an essential component of formation of clots, and it is a catalyst for cellular activities. So it combines with phosphorus to form mineral salts to form teeth and bones. Calcium and phosphorus have an inverse relationship. If one is high, the other one's low. If one is low, the other one is high. Parathyroid stimulates the release of calcium from the bones and reabsorption from the kidneys and intestines. And calcitonin blocks the bone breakdown and lowers calcium levels, and the absorption is stimulated by vitamin D. So here are the true numbers that you should know for the calcium range. It's 9.5 to 10.5. And I want you to understand that anything below 9.5 is considered hypocalcemic. Causes for that are hypoparathyroidism, malabsorption, pancreatitis, alkalosis, and vitamin D deficiency. Hypercalcemia, on the other hand, is anything above 10.5, and the causes are hyperparathyroidism, malignant bone disease, prolonged immobilization, excess calcium supplementation, and thiazide diuretics. So symptoms of hypo, that's low calcium. So they're going to have a decreased heart rate, they're going to be hypotensive, and diminished peripheral pulses. They're going to have diarrhea, numbness and tingling of the extremities, muscle cramps, tetany, convulsions. Their larynx can go into a spasm. They're going to have cardiac irritability. They'll have positive Trousseau and positive Chevex. Make sure that when you're looking at a lab result on a test and they say it's negative, that you know that that does not mean that they are in hypocalcemia. Okay, so the other thing, I want to go back to the decreased heart rate and the hypotension and the diminished peripheral pulses. That comes from the weakness from all of these muscle cramps, from the tetany, the convulsions. So respiratory failure going on or arrest can happen from the decreased respiratory movement because of the tetany and the seizures. The other things the patients can exhibit are anxiety or irritability. Hypercalcemia, the symptoms are increased heart rate in the early phase, but bradycardia that can lead to a cardiac arrest in the late phase. Increased blood pressure, bounding peripheral pulses, muscle weakness, constipation, anorexia, nausea, vomiting, polyuria, and polydipsia. Remember, that's because of the osmotic diuresis. Have too much, it's going to diurese off. Bizarre behavior and bradycardia. So again, you can have the ineffective respiratory movement again, but this time it's because of the profound skeletal muscle weakness that can occur. And you're going to have decreased or absent tendon reflexes and disorientation, lethargy, or coma. So things we need to do for the treatment of hypocalcemia: we need to monitor for INO, monitor for serum calcium, encourage them to take in calcium, and that would be from foods that are high in calcium, which would be cheese, colored greens, milk or soy milk, rhubarb, sardines, and tofu, and yogurt. And then it says administer calcium supplements. So if I'm administering IV calcium, I need to warm it to body temperature prior to giving and then administer it slowly. I need to monitor for electrocardiogram changes and observe for an infiltration and monitor for hypercalcemia because I can throw them the other direction. And then administer meds that increase calcium absorption. That would be the aluminum hydroxide. Reduces the phosphate levels, causing the counter effect of increasing the potassium. And then vitamin D, that always aids in the calcium being absorbed from the intestinal tract. Provide a quiet environment to reduce the stimuli for the seizures, and always put them in seizure precautions. Move them carefully and monitor for signs for pathological fracture. And you're going to keep 10% calcium gluconide available for the treatment of that pathological fracture. Next is treatment of hypercalcemia. You're going to monitor for INO. You're going to encourage fluid intake to prevent stone formation. And with that, you're going to monitor for flank pain and abdominal pain, and then strain their urine. You're going to encourage fiber to prevent constipation. And then you're going to eliminate calcium supplements to limit the calcium-rich foods. Those are the foods I just listed. You're going to discontinue IV infusions that contain calcium. You're going to discontinue thiazide diuretics because they need to be replaced with a diuretic that encourages calcium excretion. And you need to administer meds as prescribed that inhibit calcium reabsorption, such as phosphorus or calcitonin or biphosphonates or prostaglandin synthesis inhibitors. And if these meds don't bring it down, you need to prepare the patient for dialysis because that's what's coming. Avoid calcium-based antacids. I already covered the renal dialysis. Okay, so 2 problems that we need to be aware of. One, with calcium that's high, they're at risk for heart block. So the ECG changes that you're going to note are a shortened ST segment and a widened T wave. And then for low calcium, you're going to see prolonged ST interval and prolonged QT interval. So I want to thank you for joining us today. If you have any questions, you always can write me at rhodasummer@101andclickstutoring.com. I hope you have a good day, and I'll see you next time.